Uh, Very good morning, all of you. We are once again welcome you to this webinar series organized by the Society for Health, Research and Innovation. In our series of educating our primary care practitioners on timely topics, let me get on to some housekeeping rules. The webinar link will be available from 9 a.m. to 9:50 a.m. to join in. No late attendees will be entertained thereafter. Each attendees should have been attended till the end of the webinar to obtain the certificate for CPD points, and the CPD points are strictly adhered to the NCCPD guidelines. This is to improve and maintain the standards of the CPD programs conducted by SHRI. Thank you. Thank you for the strict adherence of the CPD regulations and your kind compliance. Asking questions, time and end of the webinar. If you have questions, please type into the chat functions. Please change your chat settings to all panelists and attendees so your questions can be answered. If you have very specific questions about your situations, please email us on officeshri13@gmail.com. Especially the today topic is the approach to patients presenting to primary care physicians following an acute traumatic head injury, conducted by our Dr. DPCK Anandalal, consultant neurosurgeon, Lady Ridgeway Hospital, Colombo. Hello, sir. Good morning once again. This is over to you, sir, now.
Okay, thanks. Now, the topic is going to be how you approach to a patient presenting to a primary care physician. So, what I mean by primary care physician here is a medical officer who is working at a general practitioner as a general practitioner or a private practice place or a small government health institution where patients are being assessed as the primary assessment in any clinical attendance. So basically, it's not going to be a formal lecture on management of traumatic head injuries, but I will guide through some of the principles which are being commonly used in the assessment of management of head injury patients. With some degree of stratification into risk assessment and some of the management strategies. So basically, this is aimed at non-neurosurgical medical officers who are at the receiving end of trauma patients in the community. So I'll basically try to cover in technical terms the initial assessment and tentative diagnosis of traumatic brain injury, and some of the resuscitation and empirical management that we can implement at the primary centers, and risk stratification to a certain extent, because most of the risk stratification is done at tertiary care centers, but to a certain extent we can do that even at a primary center. Then how to refer to a patient to a main healthcare institution, and how we should arrange the trans, and some of the important points in relation to follow-up, because now we neurosurgeons and most of the specialists in their disciplines would prefer so basically, this is not going to be a formal lecture on how to approach, the management of traumatic brain injury. It's a rough guide for you to use in decision making as a primary care physician. So what I meant here by primary care physician, either a medical officer working at as a general practitioner or a private practice place or a small government sector healthcare institution, not the major hospital settings, because there is quite a lot that can be done at primary care centers to have a better outcome in traumatic brain injury patients. So it's not going to be too much scientific and technical details, but mostly aimed at practical aspect of it. So I'll be basically covering up assessment and tentative diagnosis of traumatic brain injury, then the initial resuscitation and empirical management, risk stratification to a certain extent because that's bit of a technical activity that should be done mainly in major institutions, but there is some degree of stratification that we can do even at primary care centers. Then how we refer them to a major center and some information related to patient transfer. And then, of course, follow-up. Follow-up I particularly included here because now most of the neurosurgeons, I mean, most of the specialists would prefer some of these patients being followed up by a primary care physician because tertiary care center clinics are mostly occupied and too busy with major workload. So some of those patients can actually be followed up by primary care physicians without any problem. Before moving into the lecture proper, I just wanted to introduce few technically accurate nomenclatures because this is important in communication. Three main terms that we use when we communicate regarding a patient following a trauma, particularly in relation to brain injury. One is traumatic head injury. Other thing is the traumatic brain injury. And other one I want to introduce is the craniofacial injury, which we do not commonly use in our communications. So what the technically accurate meaning of traumatic head injury is basically the cranial injury. So it will include all the cranial contents, including the brain. So that's the lay term that we use, and that's probably the most common one that we use when we communicate regarding a patient. We always say there's a patient with head injury. And to be more accurate towards the brain injury itself, the real term is traumatic brain injury, which says there's actual injury inside the cranial cavity. But of course, most of the time, particularly in Sri Lankan context, most of the trauma patients, particularly in road traffic accidents, we don't actually get isolated head injuries, so isolated traumatic brain injuries as the main contribution. It's mainly craniofacial trauma, which means there is some facial, soft tissue, and skeletal injuries too. This is important in decision making, diagnosis as well as management, because if you say there's a patient with significant craniofacial injury or you say there's a patient with isolated traumatic brain injury, there's a significant difference in the meaning of it. I'll elaborate it when we come across with cases later, but the technical accuracy of the terms needs to be respected, I think, in communication, and these are very strictly considered in developed countries because most of the communications are being recorded, so you can actually go back and see whether your communication has been technically accurate or not. Then, of course, some management approaches. Uh, Here also I need to mention something. Now, this is essentially customized because all the trauma patients has an individual circumstance surrounding in the incident. So you can't give universal protocol or guidelines for a management or even for the diagnosis of traumatic brain injury. So basically, I will give some of the principles in a practically oriented manner so that our decision making is guided. So when you say craniofacial injury, it's basically facial skeleton and the soft tissue. One important point why you need to make that technically accurate communication is when someone says craniofacial injury, the most important thing that we bother is whether there's a airway compromise or not. Because patient may be having a significant traumatic brain injury, but the patient, the actual killer may be airway compromise. So when you say craniofacial, we know the patient's airway is compromised. So we might advise the tertiary care physician to get the patient to a nearest possible place where there's intubation facilities. So that's how the judgments are changed based on your communication. And there is very high risk of secondary brain injury in a patient with a craniofacial injury. because of obviously the airway compromise. Then there is significant or higher chance of associated cervical spine injury because the area wise there's a significant component involved. It's not just the cranium or the brain. And of course, this kind of communications guide us to have some preparation in the form of multidisciplinary management because it may not necessarily be the neurosurgeon, maybe plastic surgeon, maybe general trauma surgeon, ENT surgeon, sometime ophthalmologist, everyone has to have to be in place if the communication is correctly made. And when you say traumatic head injury, it's basically the cranial. So this is of course important in neurosurgical terms because most of these patients ends up in neurosurgical centers. So we will go into little details to see what kind of things needs to be are important in as primary care physicians. So when we say cranial injury, we always go in the anatomical layers to see which structures are involved in the trauma. So basically, we are concerned about scalp injuries, then the cranial wall, then the cranial base, then actual brain parenchymal injury. And sometimes, though the technically, when you say cranial injury, cervical spine is excluded, but there is always possibility of upper cervical injury, which can come along with cranial injuries. So the anatomical recognition is important. So when it comes to scalp injuries, now this can kill the patient, not necessarily the actual traumatic brain injury. Why I say this is the scalp is richly innervated by arterial supply and the pressure of these arteries in a traumatic situation is almost equal to maybe little below aortic pressure because there's sympathetic override in most of the traumatic situations. So the blood pressures are running quite high level than the normal levels. So it can bleed a lot, and that bleeding can actually cause circulatory collapse and death. So even if the patient has a traumatic brain injury, the actual killer may not be the brain injury; it may be just the scalp wound which killed the patient. So this is a very important thing to recognize and to implement some of the management strategies too. I'll show in a minute. And this can cause secondary brain injury. Let's say a patient has a small EDH, which is not going to cause anything. But if the scalp wound is bleeding a lot, that can cause hypovolemia and cerebral ischemia. So EDH is not the one which actually killed the patient, maybe cerebral ischemia. So that's important. When we think about management of these, it's basically hemostasis, not necessarily a cosmetic management or anything. It's basically the hemostasis so that the secondary brain injury is prevented. So this basically the damage control principle that we talk in other surgical disciplines. So the best method to arrest bleeding in the scalp wound is suturing. Why I particularly mentioned this is because of this particular technical reason. Now, if you have a patient with a full thickness scalp injury, we know scalp has so many layers. There's epidermis from the in the outer layer, then there's dermis, which is very tough fibrous tissue layer. Then there is adipose tissue layer where all the blood vessels lie. Then we have gallia, the aponeurosis, again a very fibrous tough tissue layer. Then we have periosteum and the bone. So now we can see in the anatomy, all your arteries and major arteries and veins are in the loose adipose tissue layer. And on either side, you have two tough, very strong fascial layers inside the gallia, the aponeurosis, outside the dermis. Both are very tough layers. So when we so bleeding comes from this soft fat tissue layer. So basically, what you need to do is you need to go into the edge of the wound and close the edge of the wound, not just the skin into the bone. It has to be the approximation of the dermis into the gallia. The two tough tissues are brought together so that this opening is closed. So that is how you prevent the bleeding from scalp. Mostly what happens is the general ordinary suturing carries either dermis or epidermis to make the two edges of the wound approximated. So the bleeding still can continue under the dermis. Now, this is quite important in children. Children can even go into hypovolemia and die even bleeding inside the scalp. But you won't see any blood coming because you have sutured the skin, not the proper hemostatic scalp suture. And this particular suturing can be done at the primary care center. You don't need the proper surgical suturing for this. Now, I can remember enough cases of transfers of head injury patients. When we do the CT at the receiving end, there's a very mild, conservatively manageable intracranial injury, but the whole brain is ischemic due to hypovolemia because the scalp wound has bled throughout the transfer, causing the circulatory collapse. And that can be prevented by this simple suturing. Now, this suturing is the idea is the hemostasis, not cosmesis. So you can do whatever the ugly suture, it doesn't matter. And you don't need the patient to be in a theater. You can do it in the emergency room or the place where you practice. It doesn't matter, provided that you have the suture material. So what I suggest is you use a thick, non-absorbable suture like nylon or Prolene. You can just pour betadine. It doesn't have to be sterile conditions because the idea is to prevent bleeding. And you can give local anesthesia. There's no need of general anesthesia. And even without local anesthesia, you can switch in a major traumatic situation because yeah, it's more important. The importance goes to arresting bleeding, not necessarily other aspects. But if you can give local, that doesn't matter. And you can do a continuous suture catching the dermis into the gallia before transferring the patient. And this simple maneuver can actually save the patient's life. This is a very important thing that we can do at the primary institutions. Then the vault injuries. Basically, we have depressed skull fractures and linear skull fractures. And linear skull fractures can be seen in X-ray and can be missed too. So if you don't have facilities for imaging, it doesn't really matter because the value of X-ray played in the management of major injuries is minimum because most of the surgical interventions are carried out after doing a CT scan. So if you have facilities to do X-ray at a primary center, you can do, but it's not really necessary. But if you do the X-rays, of course, you can recognize depressed skull fractures and linear skull fractures, not all the time. But then you have more evidence to say that the patient has or more objective evidence to say that there's a possibility of intracranial injury. But what I want to tell here is you don't have to transfer a patient to a major center just for the purpose of a skull X-ray because that's not really necessary in management. Then another note regarding arresting bleeding as well as the fractures. Now, most of the time when patients appear at tertiary care institutions in neurosurgical receiving ends, what we see is a scalp wound being bandaged to prevent pressure bandage to prevent bleeding. Now the problem is this is mostly ineffective. You can't. You have to apply more than sometimes 200 millimeter of mercury pressure around the skull to arrest bleeding because the patients are coming with very high blood pressures due to sympathetic overactivity in most of the situation. So it's very difficult practically to apply pressure beyond that using an ordinary gauze bandage. You can do that if you really do that effectively. That means you have applied a massive amount of pressure using a bandage into a skull where there's a possibility of a fracture. It can be a linear fracture, it can be a distal skull fracture, and if you don't have X-rays, you don't anyway don't know. And even if you have X-rays, I said it's not 100% diagnostic. So let's say you have a comminuted fracture which mostly linear, and with that much of a pressure applied by a bandage can actually convert into a depressed skull fracture, which can further damage underlying brain. Uh, so basically, you convert the linear fracture into a depressed skull fracture by applying a hemostatic bandaging. And most of the time, this bandaging is not effective in controlling bleeding also. So I do not actually advise this bandaging. In other countries, of course, there are mesh bandages, mesh masks developed for this particular purpose, but manually used ones, I don't think do that purpose. And the other thing is, I have seen in several instances, because applying a bandage around the head is very difficult because it doesn't stay. So sometimes what we do is you put another bandage across the neck, keep it. Now this is even worse than simple bandaging, because it actually can compromise airway in a trauma situation. So this bandaging practice, which is commonly done yeah, currently in Sri Lanka, I think needs to be discouraged, because I have had enough situations where the bandage is ineffective, causing circulatory collapse by the time patient come to me and the brain is ischemic. And the CT, there's only a very small tiny EDH or SDH which doesn't even need surgery. And the other thing is the possibility of airway compromise with and the underlying brain damage by moving fractured skull segment. So suturing is the ideal for arresting skull bleeding and not the bandaging. Then moving to skull base injuries, base injuries are quite common. And mostly we get injuries in anterior cranial fossa because of the anatomical arrangement of the skull. Of course, anywhere in the base of the skull, we can have fractures. So there are certain clinical features that you can recognize as a primary care physician to suspect a base of the skull fracture. Why this is important is you can miss a linear skull fracture or even a depressed skull fracture, and nothing will happen to the patient. But if you missed a significant skull base fracture, that can cause quite a lot of complications later. So in recognition of this, during the initial assessment is important. Most, I think, dreaded complication of missed skull base fracture is the CSF bleed. So you can get infective complications later. Then they can have multiple cranial nerve palsies. Particularly, they can have facial nerve palsy if the petrous part of the temporal bone is involved, and the ophthalmoplegia if nerves going into the eye is involved in anterior cranial fossa or middle cranial fossa fractures. So during the assessment, it's important to look at eye movements and the facial asymmetry so that you know there is possibility of skull base injury. Then, of course, the skull base injuries can have a higher chance of being associated with airway compromise. So that needs to be taken into account in the assessment. Similarly, craniovertebral junction injuries. And they are at higher risk of aspiration too. A little note about nasogastric tube insertion, as this sometime comes in the mode of referral even. If you have a suspected base of the skull fracture, generally we advise not to put nasogastric tubes, because if there is a fracture, significant fracture, the tube can go into the brain, and we have seen this happening. So the answer for that is it's better to avoid doing it blindly if you don't really know. I mean, as a primary care physician, we generally don't do this, but I just wanted to mention that because it's frequently being asked. So some of the important clinical features as a primary physician that you can look into in the assessment are those. One is the raccoon eyes. That's the bleeding around the eye. That's the subcutaneous. This happens when there's a skull base fracture. The blood flows through the tissue planes, and we know the areolar tissues around the eye is very loose, so you can there can be blood accumulation without much problem. So that is the least resistant path for the blood to flow in a skull-based fracture. Then, of course, Bacterial eye sign, again, important clinical feature that can say there's possibility of middle cranial fossa injury. Then, of course, if there's any watery leak from nose or ear, or any salty taste that the patient is complaining in the throat, are all indicative of skull-base fracture causing serious bleed. Now, all those patients needs to have imaging and they needs to come into a tertiary care center. So it's important for you to recognize. And if you have the facilities to do otoscopy, I think most of the private practice places have this. You can do the otoscopic examination to see if there's evidence of hemotympanum, that you can see reddish bulging tympanic membrane. That's a strong important clinical feature which says there's middle cranial fossa fractures. So those clinical features has to be looked into. Then moving into actual traumatic brain injury. Now, as a primary care physician, this diagnosis has to be clinical. And doesn't have to be a definitive diagnosis. It's basically a tentative diagnosis based on your clinical assessment. And even the treatment can be begun by primary care physician. Those are empirical treatments. So you don't really need to know what exactly has happened into the brain parenchyma to start treating the patient. Then two terms that we need to know, the primary brain injury and the secondary brain injury when we communicate. Primary brain injury means the actual primary insult causing the neural damage. So it can be extra sort of cerebral tissue or actual parenchyma itself. So like you get primary hemorrhages like extradural hemorrhages, subdural hemorrhages, intracranial hemorrhages, intraventricular hemorrhages, and brain contusions. All those injuries are primary cerebral injuries. So you can understand once you get the patient, you can't do anything about the primary brain injury because that has already happened. So most of our management strategies are based on, of course, treating the primary pathology in a way, but mostly to prevent further cerebral damage. Those are the secondary brain injuries. The secondary brain injuries means, let's say you have airway compromise or hypovolemia causing lack of oxygen supply to the brain following trauma. That is a secondary insult. Then let's say you have put a pressure bandage and you have converted the linear fracture into a depressed skull fracture causing underlying brain contusion. That's also, I mean, it's technically primary, but it's iatrogenic secondary. And of course, always you can have infective complications following trauma. So all those are secondary brain injuries. So assessment and documentation is very important as a primary care physician, not necessarily for clinical management, primarily for clinical management purposes, but there are litigations and other issues also. So it's important to document all the assessment findings. And timing is probably the most important in when it comes to both clinical management as well as litigation issues. You need to document the arrival time and the probable injury time. And if you continue to assess regularly, whenever you do the assessment and document your findings, you need to put the time. This is important, in pure surgical management also. Whenever we get a patient into a neurosurgical center, in the transfer form, we always look for this timing because this has an impact, as I will show you in later. Then you need to document the mechanism of injury, description. No, you don't need to have a massive description, but a clear communication of what exactly the mechanism of injury is. Then, in the assessment, how do you actually recognize if there's a possible traumatic brain injury? Because not everyone who comes to primary care center will have a definite traumatic brain injury. But in the history, when if the patient is complaining of headache, nausea, and vomiting, we all know these are considered the primary most important clinical symptoms to suspect intracranial pathology. So, it's very important to document whether there's a significant headache or not, and some of the characteristics of the headache. Now, most important characteristic of the headache that you need to look into, so one thing is whether it is generalized or localized. Because now this, as there's a trauma, the actual site of trauma will have a localized pain. And we are not really bothered as neurosurgeon about that particular localized pain, because if the patient has a significant intracranial injury, our worry is whether there's a rise in intracranial pressure. So if you have a rise in intracranial pressure, the headache that the patient has is generalized. So you must mention not just the headache, whether the headache is localized to a particular area or whether it's a generalized headache. That's the most important characteristic of the headache that you need to look into, because generalized headache means there's a possibility of high ICP. Then the second characteristic is whether it is sharp or dull. So if a patient has a very sharp pain, which is very much localizable, that's probably local injury related pain, because the scalp and the soft tissues, including periosteum, is innervated by myelinated large fiber sensory neurons, pain neurons. So myelinated large fiber neurons conduct fast pain or sharp pain. Whereas our inside, of course, inside the cranial cavity, the only structure which is richly innervated is the dura. The brain parenchyma has no innervation. So the dura conducts pain through unmyelinated small nerves. We know in our physiology, unmyelinated small nerves conduct slow, non-localizing pain. So if you have a dural stretch due to increased intracranial pressure, your headache is generalized. It's very dull pain. It's like a heaviness of the head, not necessarily a sharp localizable pain. So it's very important to recognize these two to say whether it's an injury related pain or whether the headache is due to a rise in intracranial pressure. Then the nausea and vomiting again is important, because nausea and vomiting can occur with cerebral ischemia. Nausea and vomiting can occur with high pressure inside the cranium itself, or else the severe pain itself can cause nausea and vomiting. So it's important to see if the nausea and vomiting is present, but you can't really say what the actual cause of the nausea and vomiting is. It's important to document. Then, of course, the hemodynamic status. This is a must in the primary assessment. As I said before, some of our trauma patients are actually polytrauma patients. Though we give a high priority to neural injuries, sometimes the actual killer may well be a hypovolemic shock. So you need to assess the blood pressure, pulse rate, pulse volume, and the respiratory rate. Now, those hemodynamic parameters are important, and if you have the facilities to check oxygen saturation of peripheral blood, that's also important to check and document, because all these things will give us clues towards the diagnosis of the overall condition, as well as to plan some of the management. So, one important thing in relation to actual brain injury and hemodynamics, the brain injuries are essentially linked to hemodynamic changes. So patient may have other injuries causing blood loss and presenting with hemodynamic changes. But even the patient has no other extracranial, extraneural injuries, still hemodynamic changes can occur, and that have a significant impact. Because as I said before, most of the traumatic brain injuries, despite the actual primary pathology, our main concern is the rise in intracranial pressure, because that's all our management strategies are aimed at controlling intracranial pressure till we diagnose the actual primary pathology, whether it's EDHO, SDHO, IVHO, whatever. When the intracranial pressure goes up, the cerebral circulation is compromised. Now, the body has very good mechanisms to counteract this effect by hemodynamic changes. So, whenever the ICP is high, your cardiovascular system changes accordingly to keep the cerebral perfusion intact. So you can have a lot of hemodynamic changes even if there is no extracranial injury. So I will introduce those changes in parameters later and the significance of it. But the hemodynamic changes are, I would say, even more important than your the neuro examination sometimes, even if it is a primary brain injury. Then, of course, assessment of neurological status in a suspected brain injury patient begins with the assessments of the consciousness. So, I think every primary care clinicians should be familiar with the Glasgow Coma Scale, which is, of course, the gold standard still in the assessment of traumatic brain injury. We don't really need to memorize this, and for a primary care physician who is not all the time dealing with traumatic brain injuries, it's not easy to look at a patient and say the GCS correctly, I mean, by memory. So what I suggest is print a GCS scale for a easy, quick assessment in your assessment room. So you can look at it and document the GCS, and the documenting the GCS on admission to you is extremely important to in the process of monitoring the patient till patient arrives at a neurosurgical center. Because in some of the literature says most important prognostic factor in traumatic brain injury is the initial GCS, if it is reliably assessed. Then, of course, you need to look for any obvious focal neurological deficits. I mainly advise to look into any evidence of weakness of limbs because this is important in the monitoring, and it has some, I mean, with it, we need to proceed with further imaging and all can be decided based on your finding. And then, of course, the cranial nerve especially look for ophthalmoplegia and facial nerve palsy because that can say that can give some clues to us the possible base of the skull injury. So those needs to be evaluated and documented at the primary care center. Even if it is a private practice, small place, I think all these things can be done because these are all clinical manual work. We don't need any equipments to do this. Uh, then, of course, other important thing you must look for is the pupils because in traumatic brain injury, pupils can say a big story in relation to the timing of the injury, severity of the injury, and the prognosis in the future. Because your pupils are innervated by mainly parasympathetics mainly comes from the vagus nerve. If you can remember the Edinger-Westphal nuclei of the medulla oblongata. Now this is it's a tiny area, but it's very sensitive to ischemia. So whenever there is increased intracranial pressure causing ischemia to the brain stem, your pupils is not going to function properly. So basically what happens is if the Edinger-Westphal nuclei is not properly giving signals to pupil, the pupil will dilate. So so the bilateral dilated pupil will tell you, can tell you whether there's a possibility of brain ischemia or in rise in ICP. And similarly, if there's a mass effect on one side, as the oculomotor nerve can be compressed because the parasympathetic nerve to the pupil comes through the oculomotor nerve. So if the oculomotor nerve is mechanically compressed by a mass effect, let's say a clot, EDH or something, again you can have unilateral changes in a pupil. So so the pupillary assessment can give us clues towards rising intracranial pressure locally as well as generally, and of course the possibility of cerebral ischemia. So that's very important to recognize and document. This is also, it's very difficult for someone who do infrequent pupillary examination to correctly recognize the size. So what I suggest is there are charts and there are sometimes pens, the pen torch with pupillary size drawn in it. So you can easily recognize, you can look at that and compare and give a rough size of the pupil to document. Then, of course, if you see any involuntary movement in a suspected head injury, brain injury patient, that's until proven otherwise, it's a convulsion. So you must document that, and if possible, you can characterize it to whether it's involvement of one limb or one side of the body, or if it's generalized, and whether the patient is spontaneously recovered or not, and whether the consciousness got altered further with the involuntary movements. All those clinical informations needs to be documented at the time of the primary assessment itself. Um, I think this I also already mentioned, the importance of headache, nausea, and vomiting. And of course, I need to mention one thing regarding vomiting in children. Now, the vomiting is important clinical feature, as I said, we look for in a patient with head injury, because in most of the guidelines, vomiting is actually considered the indication for brain imaging too. So how may the degree of vomiting, the severity of vomiting is still questionable. Now, if you go into nice guidelines from UK, you will see they are asking to do non-contrast CT brain with a very low threshold in patients with vomiting. Uh, but I think, in my personal belief is this is not very significant as it's mentioned. It's actually overlooked, I suppose. But still, the significance is there. You need to look for it. You need to document, and we also use this vomiting to decide on further imaging in traumatic brain injury. But one thing when it comes to children with vomiting following brain injury, possible brain injury, I think because we are over concerned about children, I think we always overestimate it. So sometimes I have instances, the funniest instance I can remember is a mother coming and said the child vomited 36 times following a fall. So what I think is, as we are over concerned about children, we even a little bit of drooling of saliva we consider as vomiting, and we count the number of episodes of vomiting. And when patients comes to us in pediatric practice, it's unbelievable number of episodes of vomiting. And as I think I think NICE guidelines says 3 or 4 times vomiting as an indication for CT. So all the children, almost all the children with the suspected head injury have to undergo a CT brain according to those guidelines. And sometimes this actually happens. So I actually conducted a small audit when I was I was in register training with Dr. C.K. Patrin in Homagama, because they used to send all the children with 3 or 4 times vomiting following injury for CT brain to be done in NHS. I think there was no CT there. And so I collected all the data then to see only 0.2% children had some abnormality in CT scan. So if you can imagine how the degree of overestimate that we do with vomiting. And actually none of them needed any neurosurgical intervention in even in this 0.2% patient children. So vomiting is an important thing to look for. I think we need to see if it is real vomiting. The real vomiting that you get with increased intracranial pressure is a kind of something like a project. It's a very intractable vomiting. You can't control it, and it always comes with nausea. Patient is nauseating, and then vomit. And the following vomiting, the patient has some relief, particularly headache goes down. This vomiting needs to be more technical, needs a more technical assessment, but I think this very practically and very difficult to do. But I would advise you, if possible, you document that. Otherwise, you can conventionally mention there was vomiting and this number of vomiting. But I don't think just because of vomiting, jumping into to transfer the patient to neurosurgical center or for brain imaging, it's not really needed. So that is why now if you consider, if you see the children coming to Ledrigi Hospital following head injuries, if we follow the NICE guidelines, I think almost all the children have to undergo a CT scan. but I don't think I even do at least 10% of the patients. I don't ask even 10% of children to undergo a CT scan just because of they vomit. But I would say that's kind of a neurosurgical decision because most of the guidelines suggest vomiting as an indication for CT. So you can document that and send when you transfer the patient. Then, of course, hemodynamic assessment, as I said, it's a compensatory protective mechanism following traumatic brain injury to keep the cerebral circulation intact. So all the parameters needs to be assessed and documented. These parameter changes actually occur because of what the basic principle of Cushing's reflex and the auto-regulation of the cerebral circulation. I think I'm not going to talk about the scientific aspects of this. It's illustrated in most of the physiology book. So what basically happens is when there is a head injury, when the intracranial pressure rises, uh, uh, brain circulation get compromised. So brain goes into relative hypoxia, and this hypoxia is detected by the brainstem autonomic centers. So there is the outflow going into sympathetic system, into heart and the peripheral blood vessels. So the heart will function more. The heart rate will go up, and the peripheral blood vessels constrict to divert blood. So your blood pressure will go up. So you will have some tachycardia and high blood pressure to begin with. What happened in the moment that this high blood pressure is detected by the baroreceptors in the aortic arch and the great vessels, and the afferents goes through the glossopharyngeal and vagus into the brainstem again, saying that the blood pressure is very high. Now, this input actually goes into the parasympathetic nucleus of the vagus, again, the Edinburgh like what you get in the PUP. So the parasympathetic outflow is stimulated, and we know parasympathetic outflow comes only to the heart, not for peripheral blood vessels. So the previously hyperactive heart now is trying to slow down with the parasympathetic stimulation. So your heart rate relatively comes down, but nothing will happen to your blood vessels because there's no parasympathetic innervation to peripheral blood vessels. So what happens in the second stage? Your blood pressure actually remains high, but the heart rate drops. So you get relative bradycardia with hypertension. That's what happens in the Cushing's. And this is actually protective mechanisms to give more blood to brain when there's increased intracranial pressure. And at some point, if this also fails, let's say ICP is very, very high and your Cushing's can't give enough blood to brain, brain will be irreversibly ischemic. So when it's irreversibly ischemic, both parasympathetic and sympathetic outflows to the circulatory system will be lost, and there will be circulatory collapse, which means you have hypotension and bradycardia, which is the terminal stage of rise in intracranial pressure. So now you can see if you correctly evaluate the patient's hemodynamics, you can recognize the initial phase of it's a very transient phase. Actually, you don't really see that. You can have hyperactive circulation, that's a hypertension and tachycardia, then going into hypertension and bradycardia. Then, if you don't do anything, hypotension and bradycardia, it's terminal. So your assessment and documentation of hemodynamic parameters with timing is important for us to recognize in which phase of compensation the patient is in. When the patient is, and then we can see whether the stage has changed when the patient is with us in a neurosurgical center. So basically, the scientific facts behind that. So let's say now you get a patient, and some of our patients actually polytrauma patients. So you can have a patient with actual traumatic brain injury, but patient may be having other injuries too. Particularly, this is important if the patient is losing blood from somewhere else, because that can cause further brain damage due to hypovolemia and ischemia, causing secondary brain injury. So, if you recognize some of the disturbances in hemodynamic parameters, particularly if you have detected circulatory insufficiency, the most important thing is to get the hemodynamic parameters into normal. normal values. Basically, what we call resuscitation. So I don't know which degree of resuscitation that you can do at your primary care center, but there is at least minimum that you can do before transferring, because transferring an unstable patient to a place where the proper resuscitation can be done is not actually the what happens in standard world. But I mean, in standard settings, every single medical institution, despite how big it is, should have facilities for hemodynamic resuscitation. But we know practically in our private practice spaces, and even some of the government primary care centers are not equipped with all the facilities for resuscitation. But there are certain things that you can do. Most important thing in hemodynamic resuscitation, I would say arresting bleeding. For example, like suturing the scalp wound. That can be done by at any place. So you need to do that. And the other thing that you need to know is intracranial bleeding, despite the size of the EDH or SDH, can never cause hypovolemic shock, because you can't bleed that amount of blood inside the cranial cavity for the patient to be alive. So the patient will fall and die. So you will not see a patient with EDH or SDH coming with hypovolemic shock due to that particular bleeding. That's impossible. That's not possible. In children, of course, there's a little difference, because even a small amount of blood can cause circulatory insufficiency. But adults, it is not possible. You can't say a patient is in hypovolemic shock due to EDH or SDH. That's not, it doesn't happen. So if a patient is in hypovolemic shock, with intracranial injury, it definitely says there is an extracranial injury with bleeding. So bleeding may be either revealed or concealed. It may be retroperitoneal bleeding. Your intracranial injury can never cause hypovolemia. So you need to resuscitate with the fluid resuscitation to get the hemodynamics back, despite what your intracranial injury is. So in a place where there is no proper resuscitation facilities, but I would say you can still go for crystalloid, normal saline bolus. And if available, of course, blood, but I am not quite sure how equipped we are to give blood at peripheral centers, some of the small centers, but normal saline is fine. Important thing I want to mention here is no mannitol. There is big no for mannitol. You do not use mannitol in hypovolemic shock patient with a suspected head injury in a primary care center, because that causes more damage. One thing is it causes osmotic diuresis, and patient can go into further hypovolemia. And if there is a vascular injury inside the cranial cavity, mannitol can extravasate into the already existing hematoma and drag more fluid, causing more mass effect with the expansion of the clot. So there is no place for mannitol in a suspected traumatic brain injury in a primary care institution. Uh, Even in the neurosurgical centers, that is being discouraged, but there is a place for mannitol in a neurosurgical unit if the patient is waiting to go to theater. But in the primary care institution, there is no place for mannitol, uh, and it's completely out. And the next is, let's say you don't have any facilities to resuscitate. Of course, the answer would be to transfer the patient to nearest place where there is resuscitation facility. But of course, this is a very unacceptable statement to make, because in the standard world, if the patient is unstable, it's a contraindication to transfer, because patient is going to anyway deteriorate during the transfer. But in this country, in practical terms, I think we have to do that because we are not equipped for proper resuscitation, especially intubation at some of our private practice places and small primary care units. So it's sort of out of license recommendation. Glasgow Coma scale, you need to know as primary care physicians. And the important thing is to recognize which stratification can be allocated to particular and during the time of assessment. So basically, I'm not going to go into technical details of the GCS, but these three categories are important, because this is the technically accurate risk stratification in traumatic brain injury. Basically, you categorize patient into three. If the GCS is 15 to 13 with possible head injury, traumatic brain injury, you consider that as mild form. Then 9 to 12 moderate, 3 to 8 severe. Now, you should recognize which category, which group your patient belongs to, because that gives us some clues towards the management strategies appropriate for that particular group, as I will show in a minute. And that also needs to be documented, because the patient can move from one category to the other, and the management will completely change. So if you have a patient with a low GCS, whatever the category, the first thing you, as a primary care physician, see whether there's a hemodynamic stability. If the patient is hemodynamically unstable, you can't say the GCS is due to possible brain injury. The reason is hemodynamic instability itself can cause low GCS. Why? Because if the patient is hemodynamically unstable, your cerebral perfusion is impaired and there is cerebral ischemia. So patient may not be having any traumatic brain injury, but it's just the hypoxemic injury due to blood loss. So if the patient is hemodynamically unstable, the low GCS is it can very well be due to hemodynamic disturbance. So you can't attribute it to any head injury till you resuscitate the patient and get the hemodynamic parameters into normal. And once you do that and still the patient's GCS is low, then you know there must be some intracranial pathology too. So what I want to tell this is low GCS does not mean brain injury always. It may be it's something to do with the brain dysfunction, but the actual cause may well be extracranial. The commonest is hypovolemic shock causing global cerebral ischemia in traumatic brain injury, traumatic head injury. So if the patient is hemodynamically stable, apart from significant brain injury, there are other reasons also for them to have low GCS. One thing is it can be a normal response due to psychological disturbance. We call it panic attacks and some of the acute post-traumatic responding syndromes. All those things, your consciousness can be altered without a significant brain injury. And they may well be hemodynamically stable too. So that is why it's important for you to calm down the patient with the verbal communication. Sometimes GCS may very well be 15 if you really assess and see. So that's one cause. The other thing is pain. Pain itself can cause low GCS because the pain is it's a psychological. There is a significant psychological component in pain. If the patient is in significant pain due to some other injury, your assessment of GCS may not be reliable till you give adequate pain relief. So in a trauma patient, the pain relief is very important for you to have a reliable GCS. Then, of course, the concussion. Concussion is in a traumatic brain injury, you can have functional disturbance without any structural abnormality. There is no bleeding, there is no edema, but some of the synaptic connections in the brain circuits can be disturbed because of the mechanical trauma, which we call concussion. Actually, the real mechanism of concussion is still not known, but that's what we think. So the concussion itself can cause very low GCS, but if you do imaging, you won't see anything. So that is another cause of low GCS in traumatic brain injury that you might see. Then, of course, the primary brain injury, neurological damage, neuroglial damage itself can cause low GCS. Then, of course, if there's secondary brain injury like hypoxemia and increased ICP, can cause the low GCS, obviously. So that's what most important factors, but other things needs also to be considered. Then the last thing that I want to mention is intoxication. Now, intoxication is associated with traumatic incidents, and traumatic brain injury patients can have drug intoxications. But even if you have very clear evidence of intoxication, you do not attribute low GCS to intoxication. You just basically ignore it. You can say Jason GCS is 13 because he has taken alcohol. It's a wrong statement to make in a possible traumatic brain injury. So until proven otherwise, that is not due to intoxication. You just ignore it. So those are important things in your primary care assessment and documentation. So this is, I would probably um, ignore this. This unvalidated observation data, my personal, because I was RHO, post intern in neurosurgery, worked with Dr. Saman Vadnambi. So I used to do trauma on calls quite frequently, and I actually recognized some pattern of association of hemodynamic parameters with the GCS when the patients appeared at our room at NHSA. So I collected a lot of data to see whether there's a sort of a clear pattern. I couldn't properly analyze it, but for my personal use, I have actually recognized some categories of patients in relation to their GCS status and hemodynamic status. When I look at patients today, these observations actually appears to be quite correct in the recognition of the patient status. For example, if I get a patient with GCS 12 to 9 following a traumatic head injury, when I check the blood hemodynamic status, patient has hypotension and bradycardia. They are mostly in cerebral ischemia stage. I'm just presenting this as academic interest. If there's anyone interested in doing a large scale scientific study, this can be actually used as bit of a preliminary data. In other words, if when I get a patient with GCS 14 or 13 following traumatic brain injury, I see patients normal tension and normal cardiac. Basically, the hemodynamic parameters are normal. Their GCS is mostly because of the concussion. When you follow up the patient, you see patient has actually come with the concussion. Let's say this category, if I get a patient with GCS of 8 to 3 and patient has hypertension and tachycardia when I examine the patient, most of them have had convulsive episode. So there is very good pattern. This is not reported anywhere in scientific literature, but I have, because we have large number of traumatic brain injury admissions to our room at that time, and I was post-intern 1 year. And this particular data set was I collected and I made this observation. So if anyone working in a trauma center want to do a study, this will be a very good starting point, because this is not reported anywhere in scientific literature yet. Such kind of a stratified classification using hemodynamic parameters and GCs. Probably people must be attempting and doing it, because if you come up with a good finding, it will have a very significant diagnostic and prognostic as well as management value. But just ignore it. This you can't use this for your clinical management. This is unvalidated observation in from my personal perspective. Uh, so next, so moving into mild head injury category. So if you recognize the patient to be having CCS 15 to 13, with evidence of traumatic, with suspicion of traumatic brain injury, as a primary care physician, you need to know whether you should contact or whether you should get some tertiary care advice, or whether to transfer the patient, whether you can send the patient home. So there are certain instances in this particular category. As a primary care physician, you can do the management in your own without any specialist involvement. For example, you can send a patient home following a traumatic head injury. If the patient's GCS is 15, there's only the history of trauma and your pain is localized. I said if it's generalized, that can be ICP, so you can't do that. If the patient is localized to the site of trauma and the wound does not need proper suturing, and there is someone to take care at home, and if the patient can reach medical care within a reasonable time, probably within 20 minutes or so, such patient, you can actually send home from primary care center giving simple analgesics because it's just the localized pain that you have. So you don't need to send the patient for X-ray. You don't have to transfer the patient for CT. You don't need to refer to on-call neurosurgery if the patient is in this category. You can do that. Then who need institutionalization for observation? So if the GCS is 14 or 13, this is despite intoxication. They have to be institutionalized for observation for 24 hours. And this institution is not necessarily neurosurgery. It can be done in a tertiary care center where there are specialists available, but not necessarily neurosurgeons. And it can be a patient with the GCS 15, but if the patient need wound suturing or patient has generalized headache and nausea and vomiting, there's a bleeding from ear, nose, or throat, and there is amnesia, and there is no one to monitor or keep an eye at home. Now, all those patients, even if they have GCS of 15, you have to admit to institution because they need minimum 24-hour observation. And as I said, you don't need to transfer them to neurosurgical center. You can send them to nearest major hospital. So we have general surgeons in the receiving end, and we have monitoring facilities. It's just the head injury monitoring is just a clinical monitoring. So any tertiary care center can do that. Major center, not necessarily tertiary. And of course, all these patients, if they deteriorate, need imaging. And our imaging of choice in traumatic brain injury is the non-contrast CT. Obviously, we don't have CT facilities in our primary care institution, so the patient needs to go into a such center. Then when it comes to moderate traumatic brain injury, that is when you assess the patient, if the GC is within 12 to 9, you recognize that patient to be in that particular category. So if they are hemodynamically stable, you must transfer the patient because all these patients need observation and the non-contrast CT. And that also not necessarily neurosurgery. You transfer them to a place where there is facility to get the CT scan done. So by sending, because if you consider this particular category, in my personal data collection, only 10 to 15 of them actually have had some abnormality in the CT brain. So vast majority of them actually do not need any neurosurgical attention. So you don't have to send them to on-call neurosurgical center. You send them to nearest place where there is CT facility. And based on the CT, they will see whether the patient need any neurosurgical opinion. By this, doing this, you can uh, prevent the waste of resources. Then, of course, if if the patient is hemodynamically unstable, you must resuscitate the patient. And of course, unfortunately, if you don't have the facility to resuscitate, you will have to transfer for resuscitation, which is unacceptable. But that's the unfortunate situation in the country because we don't have resuscitation facilities at all the small institutions. Then, of course, if you are transferring, you must take spinal precautions because as the patients are not conscious enough, you cannot do a proper assessment of the possible spinal injury. So all the spinal immobilization needs to be in place when you transfer. I will show it in a minute how you do that. And if you transfer, there is no place for mannitol, I said, because we are suspecting a traumatic brain injury. And there is no place for steroids because in trauma, in acute trauma, what you get is cytotoxic edema, not vasogenic edema. And steroids is for vasogenic edema, not for cytotoxic edema. So there is no place for mannitol, there is no place for steroids. Regarding tranexamic and anti-epileptic drugs, because there's growing evidence, particularly with this crash trial, it's still debated, but some clinicians now and even some guidelines recommend giving tranexamic acid before transfer on empirical ground, even if you don't know that there is bleeding inside brain. So if you really want to do that, there is no contraindication to do that. But there are, no, I mean, if you don't do that, even there, no one can find any fault with it. But it's getting popular. An anti-epileptic, again, just because you transfer the patient, there is no indication to give anti-epileptic. Anti-epileptic is the must to give if you have seen an involuntary movement in your assessment, or if there's a history of involuntary movement by the time the patient reach you, then you can give anti-epileptics. What anti-epileptics to be given, I will tell later. But there is a place. But if you don't have any evidence, clinical evidence, seizure activity, there is no need of anti-epileptics. Then the severe traumatic brain injury, when the patient comes to you, if the GCS is 8 to 3, you consider that to be a severe traumatic brain injury. It may be just concussion, but you don't know because still you need to do the imaging to see this. So again, if the patient is hemodynamically stable, you transfer. And this transfer has to be ideally intubated transfer because as the GCS is below 8, patient cannot maintain his airway. His tongue is going to fall back and secretion is going to accumulate. So there is significant airway compromise if you transfer without intubation. And all these patients, even you have a facility for imaging in the nearest place, I would suggest you transfer them to the nearest neurosurgical center because there's high likelihood of having a traumatic brain injury. And if you have to go through two institutions, I think there is a waste of time. So in this category of patients, I don't mind transferring to a neurosurgical center without going into the nearest place for imaging. But of course, intubation is a must. But unfortunately, I know in most of the peripheral care centers, small places, we cannot do that. So in that case, I don't know what the answer is, but you have to still transfer. Of course, you can, in that case, it's rational for you to send the patient to nearest place for intubation and resuscitation and transfer because if there is significant airway compromise, by the time patient reach the neurosurgical center, I think the imaging will show a global cerebral ischemia. We will very likely palliate the patient and transfer back. So I think it's important if you want to send the patient to nearest place, that has to be for the purpose of intubation and resuscitation, not for imaging. Then hemodynamically unstable patient, of course, as I said, resuscitation is the ideal if you can do that. Spinal precautions is a must when you transfer, and no mannitol despite GCS being less than 8, no steroids. You can give hypertonic saline because if when there are severe traumatic brain injury, uh, uh, there is very likelihood of cerebral edema. One thing, other thing is there is some endogenous pathophysiological mechanisms where such patients are more prone to develop hyponatremia, and that can worsen cerebral edema and complicate the overall management. So if you have facilities, if the hypertonic saline is available, you can give hypertonic saline without any problem. You don't need imaging. You can give it empirically. And tranexamic and antiepileptics, as I mentioned before, there is a place. So when it comes to transfer, ideally these transfers has to be accompanied transfers. There has to be medical or paramedical team to accompany. So I think as we have now paramedical teams with ambulance available in most of the places, this is not a big issue, I hope. But ideally, then they need to be accompanied, and ideally in an ambulance where there is resuscitation facilities, and there has to be continuous monitoring of hemodynamics. And if it's if the patient is in severe traumatic brain injury category, I would suggest you contact the on-call neurosurgical MO. You don't have to call a neurosurgical on-call consultant in the unit. You can contact the MO, and that is enough. And in personally, I prefer calling to my on-call MO than calling to me. Because calling to me actually can cause more delays and maybe more harm even, because let's say patient is intubated and being transferred. When if someone call me and they are probable traumatic, severe traumatic brain injury, I would certainly ask to transfer. But I don't know whether we have vacant ICU beds, whether we can have patients who can be moved out of ICU and can get ICU bed. I don't know if there's anything happening in the theater right now. But all those details are available with the on-call neurosurgical M. So if you contact the on-call neurosurgical MO, the plan that you get is more beneficial to the patient than in my personal case. I'm mentioning this because sometimes I just accept the patient, they transfer the patient. Once the patient is at the hospital, only the on-call MO knows, and then he or she has to struggle to find ICU bed and then to arrange the theater immediately, because we do not always communicate because our workload is very high and the calls and referrals that we get is immense sometimes. So our routine, routine procedure in place is we have a on-call neurosurgical MO who is competent enough in making decision to a great extent. And if they are in a doubt, they can of course contact the consultant at any time. So informing the on-call neurosurgical unit is important, especially if the patient is in severe traumatic brain injury category. And of course, documentation with timing is important before the transfer. And airway protection is a must. Now, as I said, if it's a severe traumatic brain injury, GCS less than 8, ideally is intubation. But if you don't have the intubation facilities, a patient still has to come to hospital. I would suggest at least the oral airway has to be put in, because one of the biggest problem is the tongue putting back, obstructing the airway, and this is very frequent cause of secondary brain injury due to hypoxia. I don't know what the critical care physicians and anesthetists will suggest and whether they agree. But I think from a surgical point of view, I would say at least oral airway in place is good till we have proper airway protection at some point. Then, of course, cervical stabilization is a must. So this is what I mean by oral airway, because that can prevent tongue falling back. And anyway, if you are transferring the patient, you have to give analgesia and sedation. So I think the patient should be able to tolerate this. But I am actually in the process of getting some information from critical care physicians to see how safe this maneuver is. But my personal opinion is transferring without any airway protection I mean, this would be much better than that. Then, of course, spine stabilization, you must transfer in a rigid board, and particular attention to spine, cervical spine, and ideally is either Philadelphia or a Miami J collar, which we, of course, don't have in primary care centers available always. So what you can do is you put two soft cervical collar, or whatever the collar you have, and two sandbags on either side, and plaster it to prevent any rotatory movements. This is, of course, acceptable when we don't have proper facilities for cervical spine stabilization. But in standard practice, there are ways and means of transferring possible with the spinal precautions. Unfortunately, we don't have. And one important thing, when you apply the cervical collar, you must make sure idea is to not to give a rigid, sorry, not to compress the neck. It's basically to prevent movements. So you must ensure that the neck soft tissues are not severely compressed, because if you have a significant venous compression, the jugular compression, your ICP can go up because of the intracranial venous hypertension. And of course, if there's a severe compression causing bicarotid insufficiency, it can contribute to cerebral ischemia. So you need to be careful when you applying the cervical collar when you transfer the patient. There has to be a little space for soft tissues of the neck. Then little bit of medications. What analgesics? Now these patients are mostly in pain. It may be due to intracranial pressure or it may be due to local injury. So it's important for you to give analgesia in these patients because if you do not address the pain, their ICP is anyway going to be high because pain itself is a cause of high ICP because patient starts struggling and there is sympathetic overactivity. So what analgesics to be given is the problem. Now, most of the time, question that we get from peripheral centers is whether it is because what we generally give is diclofenac, paracetamol, tramadol, all these things. But in severe pain, you have to go into opioids like pethidine or morphine. So while our primary care physicians are mostly worried whether it is okay to give because patients can go into sedation and that will disturb the neurological assessment. Now that fact is true, but if you don't give anything and if the patient is in severe pain, that can complicate the brain injury more because of the pain-related hemodynamic and autonomic changes. So what I would suggest is you can give IV paracetamol. We don't advise giving anything oral because in the case of patient is going theater, it's going to be a problem. So parenteral is better. We have IV paracetamol available now, but the problem is I am not quite sure in a traumatic situation to which extent the IV paracetamol is going to address such severe pain. So generally, this is going to be opioids. It's either pethidine or morphine, and if you give that and the patient's consciousness deteriorates, patient going to sedation, you never attribute it to the drug that you give. You consider that as deterioration of the neurology secondary to intracranial pathology, which means most of the time they have to undergo imaging after the transfer. But we can't help with that. So I don't advise transferring patient without giving any adequate analgesia just because of you are worried about the drop in GCS because that can cause more complication. So important thing is if you have given opioids for pain relief, you always try to avoid it if possible. But if it needs to be given, you give it and we consider any deterioration as we attribute it to intracranial pathology and do imaging to exclude anything intracranial. So that's the answer. The thing is, most of the time I am asked if it is okay to give diclofenac suppositories. Now there is a concern about giving diclofenac in a patient who can have a hemorrhagic pathology because diclofenac sometimes can affect bleeding. This is also, I think, a very theoretical phenomena. And unless the patient is having a tendency to bleed, I don't think this is going to cause big problem. But of course, if you can avoid it, better to avoid it. So, then about sedatives. Now, sometimes these patients are struggling with low GCS. Before the transfer, you might have to sedate the patient. It's okay to do that, but only thing is the receiving end medical officers should know if the patient is sedated by the time you receive the patient, just because of the patient is given midazolam doesn't mean that you need to ignore that GCS. You consider that as low GCS due to traumatic brain injury and you subject the patient to imaging. So the analgesia and sedatives are not contraindicated. That's what I'm attempting. You give it if it is needed, but the receiving end medical officer should know, should not attribute it to the drug that you have given. Then antiemetics is a must because most of these patients vomit. It may be due to intracranial pressure, maybe due to intracranial ischemia, or maybe just due to pain itself. So antiemetic is a must in suspected traumatic brain injury, and what we prefer giving is the ondansetron. And hyposmolar therapy, I said there is no place for mannitol in primary care centers. That's a big no. You can give hypertonic saline, that's a 3% saline bolus if you are transferring the patient, particularly in patients with moderate and severe traumatic brain injury category patients. And the steroids, there is no place for steroids for traumatic brain injury. That's out because I said in acute situation, what you get is the cytotoxic edema, not vasogenic edema. So there is no place for methylprednisolone or dexamethasone in acute traumatic brain injury. And the tranexamic acid, again, you can give empirically, as there are a lot of evidence to say that the intracranial bleeding, the severity of intracranial bleeding can be reduced by giving tranexamic acid. So if you have it, you can give it. Anti-epileptic, again, you give if you have some suspicion or evidence of convulsive activity, you can give. What we suggest is levetiracetam if you have it, if not phenytoin sodium, IV, intravenous, not oral. And if you can give it and transfer the patient if you have some evidence. But this is not a must if you haven't seen, if there is nothing to suggest convulsive activity. Then intravenous hydration is a must. Patient must be on a saline infusion because sometimes our transfers are very long. One of the biggest complaints that I have received from neuroanestheticists is most of the patients when they come to theaters for trauma surgery, they are dehydrated because we have kept them nil oral, so we need to make sure that they are hydrated adequately because this has a significant effect on hemodynamic stability as well as the cerebral perfusion. So it's important for them to have a maintenance fluid, provided that they haven't had any significant fluid resuscitation. In that case, of course, you need to follow anesthetist guideline on how to continue the maintenance fluid. But other patients, you can decide on your own to give some crystalloid to keep the circulation hydration intact. So that's a must. So it's are drug treatments that you need to know as primary care physicians. Then a little last bit on follow-up. Now, of course, we neurosurgeons prefer some of these traumatic, post-traumatic patients actually being followed up at peripheral centers because our neurosurgical clinics are extremely heavy, extremely overburdened, and I feel there's vast majority of patients who can safely be followed up by primary care physicians with interval appearance at neurosurgical clinics to see if there's any significant event. Now, in children's practice, most of the time, what I do is I see them at a large clinic only, depending on the situation, but mostly in 6 month time or maybe 3 months time. But they needs to be monthly seen by some medical officer to detect some of the things, and that can actually be safely done by them. So I personally advise some of these patients be regularly followed by the primary care physicians, and they can refer them to neurosurgical clinics whenever it is necessary. We don't have national guidelines on this. I'm just telling my personal preference. So if a patient, a post TBI patient appear at your private practice place or a primary care institution, what things you need to look for? One thing is the headache. Now, most of them have headaches following traumatic brain injury, whether we operate or not. Some of these headaches are what we call post-traumatic headache. We still do not know the exact mechanism, but even uncomplicated traumatic brain injury patients can have headache for months, and you can treat with simple analgesics on demand. But of course, sometimes the headache may well be due to a complication of trauma. Two commonest complications. So it's important for us to detect hydrocephalus and chronic SDH in the follow-up. So if you have a patient whose headache severity is worsening, or if it is associated with some other neurological concern, then you can refer the patient to a neurosurgical clinic. Then you need to look for the level of consciousness. If it is deteriorating over time when you follow them up, or if there's a change in frequency of convulsions, or if there's a neurological deficit or worsening of existing neurological deficit, all those things you can refer back to neurosurgical clinic for proper assessment if you see them in your follow. Then the other important thing is the behavioral changes. As primary care physicians, you might see behavioral changes in post-trauma patients when they appear at your practicing institutions. Some of them can actually have post-traumatic stress syndrome or some other neuropsychiatric conditions, particularly when the trauma involves frontal lobes or inferior temporal lobes, they can have some of the neuropsychiatric conditions. So that's also needs to be assessed by neurosurgeons. So if you think the behavioral changes are significant, you can refer them back to neurosurgical clinic. Then memory impairment is important, particularly in school children. They might come and say the school performances are going down because of the memory issue. This is also quite significant to detect in primary care practice because there is something called chronic traumatic encephalopathy, which is not rare as we thought before. So that's also something that you need to look for in regular assessment. Then some of these patients we refer for rehabilitation on discharge. So you can look into see if the rehabilitation is happening properly and if it is adding some benefits into the patient. And you can make certain alterations based on the patient's recovery. And you need to look for feeding and nutrition because sometimes we discharge patients with NGs and PEG following severe traumatic brain injury and surgeries. And even if they are not on those, the nutrition is important at least during the initial few months for proper recovery. So you can look into those in your assessment. And the constipation has to be assessed because if the patient is immobilized for a long time, that can cause constipation, which is quite disabling. So that is something that primary care physician can manage. Then decubitus altus, bed sores and contractures can be detected and can do initial management at your places, not necessarily neurosurgery. And some of them are on urinary catheters for long term. Catheter care can completely be done by primary care physician. There is no need of neurosurgical involvement in the follow-up. Then medications, this is something that I really need to tell in this kind of programs. Some of these patients, we start on anti-epileptics and we do not hope them to have it for lifelong unless it's really indicated. So we want the primary care physician to regularly evaluate the status of epilepsy, or how frequently it happens and whether it's getting worse or whether it's improving so that in our interval assessment, we can suggest reducing anti-epileptics because there is no need of most of them for to have lifelong anticonvulsants because there are a lot of side effects also. And you can even detect side effects in your follow-up. For example, patients who are on phenytoin sodium for a very long time can actually present with cerebellar symptoms later. So you can detect that and refer back to us to see if we can do any alterations. Then the other thing is, if you see a patient with some kind of a neurological complaint at your practice, and patient attribute it to a past history of trauma, that's not something you should appreciate always. Because particularly in children's practice, and sometimes in adults, they are more prone to attribute their clinical symptoms and signs even years and years after the possible traumatic brain injury. This is not good. It needs a new assessment, new evaluation at your level. No need, not necessary for you to send them to neurosurgeon straight away, but you can do basic investigation, basic assessment, and see if it's something new. The reason for this is patients who have recovered or sustained some neurological disabilities following a traumatic brain injury, not immune to not to get anything else. So they can get anything else in the brain which are known in the community. It can be a tumor, it can be infection, or it can be age-related degenerative cerebral condition. So all those things can happen in a patient with a history of traumatic brain injury, and it's not necessarily related to it. I have seen in children's practice, I have seen brainstem gliomas in patients with history of traumatic brain injury, and the parents have been attributing it to the difficulty in walking following the trauma. Uh, so this is something that you need to keep in mind as general practitioners, because uh, we need to evaluate it from the beginning as a new disease if you think it's not really related to the trauma. So those are the important things that you need to attend to as a primary care physician when you get a patient with a traumatic brain injury. That's it.
Hello, sir. There is a few questions which I have to ask. There's some questions are there.
Yeah.
What is the place for IV antibiotics in case of head injury?
There is no place for IV antibiotics in it. Now, head injuries are, there is no pathology associated with head injury which needs antibiotic treatment in the acute setting. So there is no place for prophylactic antibiotics. But I know in sometime some clinicians prefer, but there is no place. Only place I would say, if you have a significantly contaminated scalp wound, then of course you can follow your general surgical guidelines of prophylactic antibiotics. But for we do not advise prophylactic antibiotics for any traumatic brain pathology,
Uh, and
not
sir,
even for CSF rhinorrhea.
and if there is a place for burr hole before transferring with
Uh,
ICP,
There is no place. I think there has to be a place, because we have, I think, only 12 neurosurgeons now. And if the situation is not going to improve, I think prophylactic burr hole will have to come into place probably by trauma surgeons. But that's a national level decision. And at the moment, there is no place for prophylactic burr hole by non-neurosurgical teams. But this has happened before in this country and even in other parts of the world. When there are no enough neurosurgical units, of course, there was a place. But now I think as the transfer facilities are not that bad, the patients can come to process neurosurgical center, and most of the centers are 24-hour on call. So I do not advise prophylactic burr holes before transfer, and that has to come as a national policy if it's really need to be implemented.
okay, sir. Our sincere thanks to Dr. DPCK Anandalal, the consultant neurosurgeon, Lady Ridgeway Hospital, Colombo, for his excellent lectures and the precious time. Once again, thank you very much, sir, for your contribution.
Okay,
Thank
thanks.
you, sir.